Welcome back to Med Journal Club. I'm about to break down one of the most talked about and most criticized stroke prevention trials of 2025. The LAMP trial, published earlier this month in JAMA Internal Medicine, claims that a simple injection given within 24 hours of a stroke could cut recurrence rates in half. But here's the problem. The trial was terminated halfway, leaving only 36% of the patients they originally planned to enroll. So, does this drug actually work, or are we chasing statistical mirages? Let's find out. Here's the clinical landscape. Approximately 1/3 of all stroke patients have type 2 diabetes. That's a huge population. Now here's what's troubling. Even with guideline-directed therapy, dual antiplatelet agents, statins, blood pressure management, patients with minor stroke or high-risk TIA and diabetes still face a 12.8% stroke recurrence rate within just 90 days. Think about that. 13%. Despite everything we throw at them pharmacologically, our current standard therapy leaves substantial residual risk. Now, intensive glycemic control has been tried, insulin, sulfonylureas, and it doesn't substantially reduce macrovascular events. This tells us something important. Hyperglycemia alone isn't the culprit. Other mechanisms, insulin resistance, inflammation, oxidative stress, appear to be driving recurrence. Enter GLP-1 receptor agonists. These drugs have demonstrated 11 to 39% reductions in non-fatal stroke in cardiovascular outcome trials with type 2 diabetes patients. But here's the critical gap. No dedicated randomized trials had tested GLP-1s in the acute stroke setting. This is where LAMP steps in, or attempts to. The research question is straightforward. Does Liraglutide, when initiated within 24 hours of acute ischemic stroke or high-risk TIA, reduce stroke recurrence in type 2 diabetic patients? The hypothesis? That liraglutide would deliver a 33% risk reduction, a number extrapolated from prior cardiovascular trials. To detect this, they powered the trial for 1,708 patients. But here's where things started to derail. LAMP was designed as a prospective, multi-center, randomized trial using the PROBE methodology. That's prospective randomized open-label blinded endpoint design. This is an elegant approach. Patients and clinicians know who's getting the active drug. You can't really blind a daily injection. But outcome assessors and adjudication committees don't know treatment allocation. They recruited from 27 hospitals across China. Participants had to be at least 50 years old with either minor acute ischemic stroke, defined as NIH-SS score of 3 or less, or high-risk TIA using the ABCD2 score of 4 or greater. Critically, randomization had to occur within 24 hours of symptom onset. This 24-hour window is the trial's strength. It captures patients during the acute inflammatory cascade when intervention might matter most. But here's the kicker. Enrollment was terminated early. The trial screened 928 patients and randomized only 636. That's just 37% of the target 1,708. Why? Slow enrollment and financial constraints. And this decision has profound implications for statistical power. Let's look at who they actually enrolled. The median age was 63.5 years, roughly 2/3 male, 91% with a known history of diabetes, HbA1c around 8.2%. On average, they were on dual antiplatelet therapy, statins, and some on antihypertensives. Importantly, and this becomes critical later, 100% of enrolled patients were ethnically Chinese. All 27 study sites were in China. This is significant because stroke pathophysiology, treatment response, and genetic factors can vary across populations. The baseline stroke characteristics were typical for what they were targeting. NIH-SS score of 2, mostly minor strokes. About 48% had large artery atherosclerosis as the stroke mechanism. 47% had small vessel disease. This is a real representative population of what you'd see in a Chinese stroke unit. Liraglutide was started within 1 hour of randomization and dose escalated, 0.6 milligrams in week 1, 1.2 milligrams in week 2, then 1.8 milligrams daily through day 90. Both groups received standard stroke care per guidelines. Primary outcome was 90-day stroke recurrence, both ischemic and hemorrhagic strokes. Secondary outcomes included vascular events, functional outcomes, and adverse events. They used Cox proportional hazards models for the primary outcome, Kaplan-Meier curves to visualize cumulative stroke risk, and logistic regression for functional outcomes measured on the modified Rankin scale. But here's the reality. post-hoc power analysis revealed only 67% statistical power. That means if there's no true treatment effect, they'd have a 33% chance of missing it by random variation alone. In other words, there's a real possibility these results could be false positives. Here are the results. In the liraglutide group, 7.9% experienced stroke recurrence. In the control group, 13.8%. That's a hazard ratio of 0.56, meaning liraglutide-treated patients had 44% lower risk of recurrent stroke. This was statistically significant, but confidence intervals were wide, 0.34 to 0.91. This wide range tells us precision is limited due to the small number of events, only 69 total stroke recurrences. Secondary outcomes look good. Vascular events occurred 47% less in the liraglutide group. Functional outcomes were even more impressive. 87.3% of liraglutide patients achieved excellent recovery, modified Rankin scale of 1 or less, versus 77.8% of controls. The odds ratio was 1.95. But, and this is crucial, functional outcomes are easier to achieve in minor strokes. Both groups had predominantly NISS scores of 2. So these differences, while statistically significant, may be reflecting the natural trajectory of minor strokes rather than a transformative effect. Mechanistically, this early divergence, which appears in the Kaplan-Meier curves around day 30, supports the idea that liraglutide works via rapid improvements in insulin sensitivity, reduction of acute inflammation, and enhancement of vascular endothelial function. Subgroup analysis also showed greater benefit in younger male smokers. While this sounds promising, this study was not powered to confirm this. Safety was reassuring overall. Symptomatic intracranial hemorrhage occurred in 0.3% of the liraglutide group versus 0.6% of controls, not significantly different. But here's the signal that matters: gastrointestinal side effects. 18.9% of liraglutide patients experienced nausea, vomiting, or diarrhea, compared to just 4.1% of controls. That's a fourfold higher rate, statistically significant and clinically relevant. Why does this matter? Because 10.1% of the liraglutide group discontinued the drug prematurely. That's genuine clinical non-adherence driven by side effects. In real-world practice, you might see even higher dropout rates. Hypoglycemia rates were similar between groups at around 7 to 8%, and all-cause mortality was low and comparable. This study had a few strengths. Design was rigorous, with blinded endpoint adjudication minimizing ascertainment bias, and rapid randomization ensures early intervention during the critical window. Intention to treat analysis also reflects real-world efficacy. The results were clinically relevant as well, showing practically useful primary and secondary outcomes, as well as safety profile. External validity was also reinforced by comparable findings from control group compared to prior studies. Now let's get real about the limitations. Yes, this is the first trial of GLP-1 agents specifically in acute stroke. Yes, the results are numerically impressive. But the trial is fundamentally underpowered. Early termination because of financial constraints isn't inherently disqualifying. It happens, but it means we're left with 69 events when they plan for hundreds. With this sample, we can detect only large effects reliably. Medium effects? That's where false positives live. Second, open-label design creates performance bias. Patients and clinicians know who's on active drug. This can influence symptom reporting, diagnostic testing referrals, or lifestyle modification intensity. Third, they didn't collect standardized HbA1c or weight data at 90 days. So we can't determine if the benefit comes from improved glycemic control, weight loss, or direct neuroprotective effects. The mechanism remains inferential. Lastly, generalizability is severely limited. All patients were ethnically Chinese in China. Stroke pathophysiology, treatment response to GLP-1 RAs, lifestyle factors, diet, all of these can vary across populations. Can we apply these findings to European, African American, or Hispanic populations? Honestly, we don't know yet. And finally, this is liraglutide specific. Weekly GLP-1 RAs like semaglutide or dulaglutide have different pharmacokinetics and adherence profiles. Can we extrapolate? That's a question for future trials. So here's my bottom line. This trial provides interesting, hypothesis-generating evidence that liraglutide may reduce stroke recurrence in Chinese type 2 diabetic patients. But it is not, and the authors themselves acknowledge this, practice-changing evidence. We need larger, adequately powered international trials. We need diverse populations. We need longer follow-up beyond 90 days. The signal is worth investigating further. The mechanism makes biological sense. But jumping to routine clinical implementation? That's premature. Future studies may want to focus on higher risk subgroups, such as younger male smokers. And at the systems level, healthcare administrators should consider cost-effectiveness analysis given the cost of liraglutide and its relatively high gastrointestinal side effects. So what do you think? Should we be treating acute stroke patients with GLP-1 agents based on this trial? Would this trial influence your practice, even if your patients are not ethnically Chinese? Or you stock other agents such as semaglutide? Drop your thoughts in the comments below. If this analysis was helpful, please like, subscribe, and drop your thoughts in the comments. Thanks for watching.